Firstly, thanks very much for having me, and also just the fantastic talks that we've had so far. I remember starting out when I started my PhD thinking about all of these things, and so it's really nice to hear this discussion. And hopefully, I'll take a lot from what all the speakers have already said, but focusing it now into database management committees. So hello, I'm Sarah. I'm a radiology registrar just down the road at Barts. But I'm mostly talking about my work that I carried out as a PhD student at the University of Cambridge before I started radiology training. Few disclosures, PhD was evaluating multiple AI companies, and I still work as a visiting researcher there, and also on the radiology AI training historical. So I see a lot of interesting manuscripts coming through in different ways around the world of working in the data AI sphere. But none of this work ever happens with just one person. I think, as we've seen already, the medical physicists, the information governance teams, the patients, is such an important element. So it's really important to just highlight how many people go into a project like this, and just around the country, how many people are involved. So overview of what I'm going to talk about today is firstly, what is DAC, or Database Management Committee, depending on how you refer to it, the background to our project, just to put us into context, and then how we implemented it. So as we've heard about today, data is the 80%, I'd say, of AI research. The first year and a half of my PhD was all about how we're going to get the data, how we're going to structure the data, how we're going to put it out packs, all of these discussions. And really, as a clinician, and something that we're pleased to do as a clinician is read the DICOM standard, and I probably enjoyed it and learned a lot by doing it, so I recommend. But data really has to be handled with care, and really great integrity. And I think that's what we've heard so far today, but also just how much of a precious resource it is. And the unique thing that we also heard is just about how data in AI, it's this volume of data that is required. We're not talking about a couple of hundred patients, we're not talking about a couple of thousand patients, talking about hundreds of thousands, if not millions of patients, and just how a great resource radiology packs are. But with that volume comes that trust and that care that we've heard so far is really important. And all of these legislative, DPA, Health and Social Care Act, that really needs to be taken into account from a legal aspect, but also from the governance and ethical aspect. And also, I think I just want to highlight how much of a shifting sand, almost the governance aspect, also the legal aspect around this really is, and how much it's changed really just from my very short experience since 2017 in this space. Things have already moved on so much. So just be astute to the fact that what I'm saying is from our context, and also dates back somewhat to 2019 to now, but this I can see, as we've just already talked about, will continue to move and shift. I think we've already highlighted this, but when I started, this had just happened in 2017, and I took this to my supervisor and said, this, for me as a young clinician, was really something that switched me on to how much we have to think about that patient trust and that care and attention when dealing with patient data. Quite interestingly, if anyone wants to read the outcome of this, was finalised this year, but started back in 2017. So these three words, I was talking to, actually my sister is in the audience, who's also a radiologist, and I was talking to her about this talk. She very kindly helped me go through it the other day before giving it. But really these three words came up, so safe, ethical and controlled, when talking about patient data, and really a focus, I think, as we've already heard from the previous speakers, about how much we really have to understand the patient's views. When it comes to data, I think from clinicians, we handle data all the time and kind of get used to tapping people on the phone like yesterday on call or sending internal text messages, but it's when we move outside that space into research and like moving data around that we have to think again really about how we're doing that. So completely, what would a patient want to know? What's the knowledge that we need to maybe give people to put this into context about what is pseudonymization? What is a safe research environment? The type of consent that we're going to look at, is it an opt-out approach? Do we need Section 251 approval? Are we going to go and get consent from all the patients? And really, again, all of the array of options. Shared or access data, how data is going to be shared? Is that going to be an open source, as you already heard? The limitation for that, or is it going to be a more kind of the XNAT approach of more secure environment and CETA? And then also, who's going to have access to that? Is it a medical physicist? Is it a direct care team? So really, data is that precious resource, and not one to be kind of, I think, previously been shared around quite a lot, but now to be really brought about how precious it is. And I think Andrew brought up this provenance issue of data, and one that I hit at the very beginning of my PhD about how if data has previously been shared or has previously been extracted, you really need to keep track of that data. And the main reason for that is that data leakage when we're talking about AI. When we come around to, as I found, then having to test different commercial AI companies, having to figure out what data they trained on and make sure that none of my testing sets have that data in, and also going forward, knowing that maybe this data is going to be used again and again and again, and how we keep track of that. So back in 2019, this was the only document that I could find from the NHS really about AI in this space. Now, this is up to date if I can make it, being a busy radiology registrar, but back in the day when I had a little bit more time as a PhD student, I read all of these, and as I say, it kind of highlighted how this discussion was moving on and how we were becoming a bit more switched on to how data should be smartly used so it can be reused. So the HDR UK nicely published this in 2021, which defines, coming on to our topic of this talk, what a database access committee actually is. I'll just highlight these keywords. If you're like me, I'm dyslexic, so I find it quite hard to read a lot of text, but basically accessing, managing, and administering data. And this is also a brilliant database access committee paper written in 2020. So it's really talking about how we kind of just take a pause when we think about how we're going to use that data. We have a committee of people who have different expertise to make sure the correct people are accessing it. It's well managed and curated, and so that this data resource can be reused. So my project was called CC Media. You can Google it. There's hopefully a nice summary of it on the Hickman website. But it had two aims. One, to build a large database of mammograms. As we've heard, breast screening is a prime task for AI, as 2 million women screened each year. So we were trying to collect and store these mammograms and evaluate different AIs for their different applications in breast screening. So in total, for a PhD, we extracted around 100,000 women's mammograms, so lots of mammograms. And created this database called the CC Media database. And from my disclosures, there's no surprise that these are some of the companies that we then would bring in and evaluate. And there's lots of different ways in breast screening in which you can deploy AI into a breast screening workflow. So we really wanted to see at the time, do this benchmarking. I was having a talk after lunch about benchmarking, about different ways you can drop AI into the breast screening workflow. But before doing that, we went and spoke to the NHR Cambridge PPIC because I was very conscious about what are the patients going to think about my plan. So before that, we went and did an internal review, not one with words. So my lay material needed a bit of working, and very helpful. The Cambridge PPI committee helped with that. And then went out to a local science festival, and then nationally we carried out surveys to look at patients' opinions on different ways that we were proposing to both extract, store, and then share their data. And interestingly, I think we've already highlighted all of these points so far, but the two main concerns were the data in terms of consent, how it is to de-identify the data in their patient's privacy, and also the commercial company involvement was a big discussion point. So from that, I'm doing a bit more reading, saw that database access committees would be probably the best way to make sure we were addressing these concerns of the patients. And also seeing that shifting stand, making sure we had all the appropriate people around the table to make sure we were keeping up to date with the guidance, or kind of coming up with our own way of doing things as well, that we felt comfortable in the local research team that we were addressing these. The other thing to note was also this carried out during COVID. So we also had, I think, raised awareness around track and trace at the top of the line, how patient data was being stored and shared. And really, I heard that a lot from these sit-down discussions with the patients as part of our PPI project. So who was on our committee? And I think this is up for discussion, who should be on the database access committee. But from our project-focused database access committee, we had the PI, we had data managers, and we had representatives from, because we were working across 2 sites in East Anglia, clinicians from each site, a patient representative, and then our research governance leads at the university and the hospital. So each person had a particular kind of role that they bring to the table, but as a committee we work together on these. So the PI bring the oversight of the overall project and aim, The data managers were both medical physicists and clinical scientists who had that expertise in PACS and DICOM. Those representatives from screening programs, understanding how breast screening works is a job in itself. And then the patient representatives helping, as I say, was that patient communication and commercial views. And then lastly, the governance leads helping us navigate those waters of all those documents. The first thing in the committee we really had to nail down for all those ethics applications was how we were going to move the data. So this is just an example from the 960,000 word document called my thesis that summarised what exactly we did. So basically we extracted data and then put it in a secure store at the University of Cambridge, following all of those DICOM standards with the real great help of Martin's here, with the medical physicist from Cambridge. Then we had to figure out, once we got the data, how we would share the data. So one option is we highlighted is that Kaggle open source approach, which again, would, in terms of a patient trust approach, we didn't feel that most comfortable with, and also didn't really feel it met the aims of our research, which was more focused. So do we have to send which we want to work with these specific companies in the breast screening field. So the question is, if we send the data to the companies, how do the companies come and access the data? And really, we came down to this approach of bringing the companies in and separating them from their tools so that we could independently benchmark and evaluate each AI. But also this meant that we had full control over our data and that the data didn't leave the secure store endpoint. But again, this is just an example of how we carried out this type of work. And I'm sure there's people in the room who have carried this out differently. Coming on to those patient concerns about patient privacy, opt-out, consent, and how we were informing the patients. There's just some examples, so I won't go into detail because we've already talked about how to navigate DICOM, but we would think about the identification and pseudonymization and really nailing down, as you said, into those dates and those private tags and making sure we were confident with our data being pseudonymized. Taking into account this was the old original opt-out document into our consent process, and then also making sure we had as much as possible informing the patients and really trying to work around how we inform the patients with this research being carried out and that they could contact us if they have questions. Other roles of the DAC, so we've talked about collection and transfer, access and management, so every researcher who has or data management about access to the data would go through the DAC to be approved. That also meant that every company that was accessing the data would also have an initial meeting with the study team. We'd fill out a form and that would go to the DAC to make sure that they met the requirements to be installed, because as we've highlighted, the limited resources that sometimes these projects have. And then finally, how our project outcomes were then disseminated. And I was at one of Andrew's talks at LCR conference and highlighted the 5 stages, and I think those are kind of key things to come back to. In terms of how the DAC functioned day to day, so we had to make sure we had a 6 monthly meeting, which again, just at the time of setting up meant that we definitely had a day in the diary, but there was constant correspondence, so via email if anything arose in the meantime. And we've already talked about most of those processes, but yeah, in terms of getting the company the access, there was a flow and lots of documents in terms of making sure that process was included the DAC and was documented. So that's, again, just to summarise who was on that AI committee. So I think it's really vital that we look at how we're ultimately that we have the appropriate expertise on the DAC, that everybody brings something different to the table, and that we are involving patients in this process, because ultimately it's the patient's trust at the end. We are using their data, and that they're taking into account each step. I've talked about it from a project-specific level, but I do understand that this could be from a departmental, regional, or even national level. So very happy to take questions in discussion. I understand I stand between you and lunch, so I will finish there. So thank you to everyone on the committee. And